first I invite a young speaker, Dr. Subhankar Chatterjee from Kolkata. He's an MBBS, MD Medicine, MRCP UK, postdoctoral trainee, Department of Endocrinology, Medical College and Hospital, Kolkata. And he'll be talking about a relatively rare topic, which has probably never been talked about in this conference or probably, I don't know of any other conference, diabetic striatopathy. Striatopathy, a rare neurological complication of diabetes. Dr. Chatterjee.
Thank you, sir. Thank you for inviting me and allowing me to talk on a topic in which I work since my MD medicine days. So my today's presentation is on diabetic striatopathy. It is not moving. It's moving. Yeah, thank you. So, movement disorders in diabetes is not a new thing. It has been, it can occur due to multiple reasons. Mostly, it can be as a complication of chronic microangial complications like vasculopathy, like vascular Parkinson's, neuropathy, leading to RLS, like restless leg syndrome, and most commonly nephropathy, as you see in uremia, metabolic acidosis, and dyslipidemia. Hyperglycemia can cause a range of movement disorders and also syndromic diseases, which rarely can coexist with diabetes as well as movement disorders. And what I am talking today is on acute onset de novo movement disorders solely due to hyperglycemia. Now, when you say that, we broadly divide the movements disorders caused by hyperglycemia in two groups. One is choreopallism, another one is non-choreopallism. In the choreopallism group, that is apart from the choreopallism and pure chorea, there is choreodystonia and also choreoathetosis. Among the non-choreopallistic groups, the most common is the different kinds of myoclonus and also the dyskinesias like PKD, like paroxysmal kinesia, PNKD, PED, hemiplegia spasm, tremor, acute reversible Parkinsonism, restless leg syndrome, etc. Now, these choreopallistic movements in diabetes was originally described by Bedwell in 1960, and since then various terminologies have been used, and to ameliorate such heterogeneity, a unique term, diabetic striatopathy, was introduced by Professor Abbey in 2009. Now, how we define diabetic striatopathy is defined as hyperglycemic conditions associated with both or either one of the two following conditions. Number one is acute onset choreopallism, and two is striatal hypertensity on CT or striatal hyperintensity on T1 weighted MRI. Now, recently we have proposed a new classification system of diabetic striatopathy, which has also been included in the endotext. We have broadly classified diabetic striatopathy into three groups: symptomatic DS, clinically isolated DS, and radiologically isolated DS. In the symptomatic DS group, there can be two types: concordant or discordant. Concordant is when the lesion in the neuroimaging is contralateral to the side of the movement disorders. The discordant group can have three types. One is radiological lesion on the same side of the movements. It can the unilateral radiological lesion with bilateral movements, or bilateral lesion in the MRI but unilateral phenotype expression of the movement. Now, what is the magnitude of this problem? The real epidemiology is really scarce. All are prospective study. there in various single center study, there can be, you can see on retrospective analysis, 0.16 to 1.2%. So seems to be rare. But the thing is that we can, various large scale studies have confirmed that the most common cause of acute onset choreoballism in emergency setup is non-ketotic hyperglycemia. And in our cohort, we have worked in a movement disorder clinic in a tertiary care center where 552 patients with the span of 10 years came, and we have found that 70.4% of them were diabetic. Again, I am mentioning that acute onset, new onset movement disorders. Now, on global scale, the most commonly reported cases are from Asia, most commonly from Taiwan, followed by Japan. India comes at the 6th place. But why Asia is most common? Probably the most important cause is that underreporting from the West is probably the most important reason. Apart from some have speculated about the genetic predilection, poor glycemic control among Asians, and also probably greater glycemic surge during postprandial period among Asians. Now, DS is generally considered disease of elderly, but can be seen as early as at the age of 8 up to the 9th decade. Among the Indians, like other complications, it tends to present earlier, in the 5th decade. Now, in most the global data, there is female predominance, but in our study, we have not found any sex-specific predominance. Now, mostly type 1 and type 2 have been well reported, but we have also reported a case where type 3C diabetes presented with this kind of acute onset movement disorder, it is hypofacial spasm. Now, mostly the long-standing diabetic with poorly controlled diabetes are the hallmark feature, but please remember that they can be the presenting feature of previously undiagnosed diabetes. Like this, we have previously reported that different kind of myoclonus, like action myoclonus and diaphragmatic myoclonus in an old lady who was not previously diagnosed. It was her first presentation with this kind of abnormal movements. Not just hyperglycemia, but also its chronicity and acute surge. Acute surge and also the acute fall in the blood glucose level plays the pivotal role in the movement generation. And mostly seen in the state of the non-ketotic hyperglycemia, as it reflected by the explained by the GABA theory. What happens in the ketotic state? There is always so much of ketones that GABA tends to regenerate, leading to the the GABA level in the blood remains high, so the propensity to develop the abnormal movements is little bit lesser in case of ketotic state than non-ketotic state. But we have also reported this kind of movement disorder in case of decay, like these two cases. One is classical choreoballistic movements and another one is faciobacterial myoclonus. Like this. This is the faciobacterial myoclonus. First presentation in type 1 diabetes, little bit late presentation. The boy was 23-year-old. Now, most commonly, when we talk about the choreoballistic movements, most commonly involved area is arm and leg, and the face was the least commonly involved. Bilateral involvement was noted in the 9.7% of the patients. Importantly, bilaterally was more common in non-choreoballistic movements than the choreoballistic movements. So, here the key message from the clinical features is that although we know about the choreoballistic movements in diabetes, the non-choreoballistic movements are equally well prevalent, and non-choreoballistic movement tends to get misdiagnosed frequently. So, and it underscores the importance of sensitizing the physicians to the fact that hyperglycemia can be associated with multiple movement similarity other than the classically described hemichoreoballistic phenotypes. And always remember that even if one cannot decode the exact semiology of that involuntary movements, always check an random blood sugar immediately, irrespective of the past history of diabetes, before asking for any costly time-consuming investigations. And now, apart from the movement disorder, we are also seeing the expanding clinical spectrum of the striatopathy, including seizures, dementia, behavioral alteration, and most importantly, stroke. Now, one of the things that I want to mention here, the hyperkinetic movement disorder, the common mimicker in this setup is an EPC, epilepsia partially spontanea,
Dr.
like this
Chatterjee,
one.
please finish in next 1 minute. Yeah. Please conclude in next 1 minute.
The classical neuroimaging feature is the striatal hypertensity in the CT or hyperintensity on the T1 MRI. The audit is the most commonly involved part. I just want to highlight here that don't wait for the neuroimaging, because many cases the neuroimaging may be completely normal, and the most important pathological point in this aspect is that the gemistocytopathy of in the putamen, and intensive glycemic control is the treatment of choice in this situation, and mostly the glycemic control alone reverses the situation and carries an excellent prognosis. Some patients may require additional therapies like haloperidol or tetrabenazine. And here he mentioned recently some still the current knowledge gaps in this field of study, including the knowledge gap between the different specialties, neurology, medicine, endocrine, and general physician, knowledge gaps in the epidemiological parameters, knowledge gap in the true pathogenesis and clinical conundrums, and understanding the radiopathological correlations and the treatment and further prognosis. So the take-home message is that movement disorder in diabetes is actually not rare, rather unrecognized. Although hematuria hemiplegism is classically described, all possible movement similarities can occur. Always check for blood glucose in any patient with acute onset movement disorder. Contralateral striatal T1 hyperintensity on MR or hypertensity on CT is the classical, but may not be present in all. And achieving hyperglycemia reverses movement disorder in most of the cases and carries an excellent prognosis. Thank you, sir.
Thank you, Dr. Chatterjee.